for the past 2 years, where we developed this toolkit together. We have been working on it, engaging children with disability in the field. I am very active in the evidence community in seeing that children with disability are not left behind the evidence-based practice train. I have a background in accounting and finance. I have a background in accounting and finance, but then when I started work after the university, I started working with children with disability. I grew up in a community where we have children with disability. That gave me the zeal to work with people or children with disability. So that's just a brief about who I am. And here we have the slides. Good, thank you. Thank you very much, Patrick. Thank you, Lynn.
So please go ahead and I'll try and follow along with the slides, but feel free to tell me to advance if I miss anything, okay?
Yes, all right, thank you. So today I'm going to be presenting on getting research into households and communities of people living with disability. According to the 2030 agenda of SDG, it says that we should leave no one behind, but people with disabilities seem to be left behind the evidence-based practice train. So people with disability, while working with people with disability, rather, we realize that most of the current practices are household and community level and policies. They were not evidence-based, and a lot of interventions that were directed towards people with disability were not effective. In Cameroon, for example, public policies provide for free basic services for people with disability. These policies have been developed with inspiration from the UN Convention of Rights of People with Disability, but they remain a paperwork because implementation is poor, because they lack strategies to implement it better, they lack understanding of the policies, and there is little or no participation of voice of people with disability in these political processes. And this is leaving them behind the evidence-based practice train, because the evidence community has not developed creative approaches that can bring research evidence into practice and policies and communities in a way that will reach people with disability. So in this project, you can go to the next slide, please. In this Wakka project, we seek to use innovation and best practice to improve the livelihoods of people living with disability using innovation and best practices. So a little background about the disability situation. We have here a graphic of stats globally. We have 15% of the global burden being people with disability. In Cameroon, we have about 10.6%. And in Northwest, where we have this project being implemented, we have about 23% of people who have a disability. So next slide, please. In this project, we seek to improve livelihoods of people with disability using innovation. This innovation is the eBASE Family Centered Evidence Toolkit for Disability, which we developed at eBASE, and it is developed using best practices. This project was funded by the Wakka project and SSBK in Holland. So this project has been running for the past 2 years here in the Northwest region. Slide, please. Okay, so through this presentation, we're going to see how we developed this toolkit and how we have been using it. And then we are going to see some results so far, as we have been doing a lot of work with the children with disability here in Northwest. So prior to our intervention, most children with disability had unmet needs, and their rights to health, education, social well-being, livelihood, and empowerment were not being met. So we started by doing a formative study to gather experiences of children with disability within their households and communities to design To inform the design of the intervention, this formative study included key informant interviews and focus group discussion. Slide, please. So for focus group, for key informant interviews and the focus group discussion, we had about 8 key informant interviews and 1 focus group discussion. And the essence was to prioritize outcomes of interest of people with disability. So we conversed with their families and asked them about their experiences and asked them what it would take or what they would want to see to say that the livelihoods and the needs of their children with disability are being met. So after conducting these interviews, we uploaded them. They were transcribed and uploaded into Dropbox, where we coded in Max QDA. And we also, this focus group and key informant also informed us of the current practices in households and communities of children living with disability around Bamenda. So after this stage, we then moved to geomapping the children with disability using Google Maps and Magpie, using a data collection tool which we adapted from the Washington group. So as you are seeing this, you see this graphic here, it shows a look. Each balloon stands for a child with disability around Bamenda, and they have different, and it's just a snapshot of a different information. For example, this is zooming on the mental health situation of the children living with disability, where we have blue, they are being depressed. They get depressed at least once a year. Then yellow, we have them being depressed at least once a week. Then we have red at least once in a month. So that is the kind of data, and this data is particularly important for people, for decision makers, as they are able to see where the child with disability is particularly located, and they are able to make informed decisions informed decisions that can help the child with disability. Slide, please. So after, we also had stakeholder sessions with the families, where we discuss about their experiences and how they are coping with their children with disability. Slide, please. Okay, and we have also, through this process, we have also been working with the policy makers to ensure that policies are informed, or they engage people with disability in policy. So we facilitated sessions with district medical officers, and the regional chief of people with disabilities, to create opportunities for people with disability to be able to join these structures. And we also had stakeholder sessions, as you have seen in the previous picture, with families, to discuss the importance of joining these structures. We're going to see this in the slides ahead. Slide, please. And so after conducting these key informant interviews or formative study and geomapping the location of children with disability, we went ahead to conduct a rigorous search of scientific research evidence to now model our toolkit. Here we search databases, including Campbell, Cochrane, JBI. We also search government and development agency databases. We also email authors like Lynn who are interested in disability works. And in our search, we had developed a PICO to carry out this search. And in our PICO, we had population, people with disability in low and middle income countries, and we have intervention, effective interventions to improve livelihoods of people with disability, and we have control being current practices, and outcomes being improved livelihoods as measured by improved well-being. And in our search, we had 2,000 plus studies, and out of these 2,124 studies, we had 95 primary studies, 53 systematic reviews. We also had 6 guidelines, 5 of which were WHO guidelines and 1 local guidelines. We also had the national policy, the UN Convention on Rights of People with Disability. We also had the Sustainable Development Goals. And after getting all this research evidence together, we now synthesized it and model our toolkit. Slide, please. So this is a graphic of how we model the toolkit by combining results from the qualitative study and research evidence based on the national policy and the WHO community-based rehabilitation metrics, moving from from current practices. So this WHO metrics helped us to model this toolkit, as we did it using the 5 categories of health, education, livelihood, social well-being, and empowerment. So in this graphic, we see that we move from the axis here are the 5 main categories. We go to current practices, then we have the evidence-based recommendations, we have the clauses for how this is impacting on SDGs, and then we have consideration for training models, and then to the extreme right here, we have the evidence that back up all these evidence recommendations. For example, in the current practices here, we have people with disability not attending school effectively, children with disability not having assistive devices, they not socializing well with the community, having psychosocial unmet needs, not having their disability cards, not having insurance. So those are some of the current practices. And we have some best practices here, being that children with disability should go to schools, and the schools should be adequate. Schools should have adequate rooms for accessibility for children with disability. Children with disability should have good medical care, nutrition. Services should be provided in such a way that people with disability can be able to access it. And then we have clauses for contribution to SDGs, for the Sustainable Development Goals. By 2030, according to the SDGs, it says ensure that all men and women, in particular the poor and vulnerable, should have equal rights to economic resources as well as basic services. So that is how we model the toolkit. Slide, please. Can we move to the next slide? So this toolkit, this is the picture that just passed shows a summary of how we developed the toolkit, from the current practices to the evidence-based recommendation. This is a sneak peek of the eBASE Family Centered Evidence Toolkit. So the toolkit basically is a scorecard that audits families of children with disability on engagement with evidence-based practices. So for example, the community health workers, because this toolkit is basically used by community health workers who go from household to household, visiting them and giving them this recommendation. So they ask families questions such as, do they discuss health issues with their child with disability? How often are they able to send their child? Is the child with disability attending school? Do they have all their school needs? Do they have access to technology for learning and entertainment? Do they associate with the community? Are the parents, do they participate in community education, community health, and such questions? And each question have scores stacked to it, such that when you answer a question and they check these boxes as you're seeing in this graphic, it's going to give you a score. For example, here, as we are seeing this question, discuss health issues with the child. If the answer is no, they will score a 0. If it's yes once in last week, they will score a 1. If it's yes more than once in last week, they will score 2. Just like that. Does the child have a disability card? If it's yes, it's a 1. If they're in process, if they're in process, it's a 1. If it is a yes, they score 5. If it's a no, they score 0. Such that at the end of the day, when all this data has been collected, the community workers now upload it into eBASE server, and they download it, and they analyze the data. At the end of the day, after analyzing this data, families that score above 60% compliance with the evidence-based recommendation, they are rewarded a seed fund to start off an income-generating activity. Please, you can go to the next slide. Okay, this is a snapshot of how the data is uploaded, how the data looks like in the eBASE server. This is a snapshot of Magpie. Next slide, please. Okay, so this is a picture that shows how we had trained community health workers. After developing the toolkit, we then went ahead to train 5 community health workers who go from household to household. After every 2 months, they visit households to ask them basic questions. They ask them, the toolkit is made up of 32 questions or 32 variables built on the 5 community-based WHO CBR metrics of health, education, livelihood, social well-being, and empowerment. So they ask them these questions to give them recommendation. The reason behind all these questions is because evidence suggests that when parents discuss health issues with their children, this improves their health outcomes, it builds trust and increase chances of compliance with treatment. And when they have insurance, it significantly reduces cost and the burden on the parents, keeping the child healthy. And when the child spends time, or when the family spends time bonding with the child with disability, it positively impacts on the child's well-being as it builds the child's self-esteem. It helps them to interact better with their community. So our toolkit is an evidence portal that synthesizes complex research evidence to households, so that household practices are audited and they provide recommendations based on best available research evidence. So this is a snapshot of the income generating activity here for families that reached a score of above 60% compliance with the evidence-based recommendations. Next slide, please. This another snapshot. Next slide. This is a family, a beneficiary who are very happy with having received the income generating activity. They choose poultry. Actually, we have 3 choices where families, but they still have the liberty, it's at their discretion to choose whatever business they want to do to support the needs of their children with disability. Here we have results from Max QDA after coding the data from our formative study, where we developed 340 codes that describe experiences of people with disability in communities, 29 categories and 90 subcategories, 340 coded segments, and we identified 12 current practices, some barriers, 12 facilitators, 16 coping strategies, and we also mapped out how conflict is affecting children with disabilities. And we also aligned them to the 5 CBR axis and developed guidelines for families of the children with disabilities. Slide, please. This graphic here also shows barriers to accessing basic services to children, accessing basic services by people living with disability here in Bamenda. Slide, please. All right, so now we move to the results of the results after household visit. This results is a segment of after 2 months visit or after our interventions, after a period of 2 months. So after the community health workers visited, this is the empowerment. We're going to have all the categories and see how it moved. For the empowerment, we had about 21.7% change, or weighted average change for the empowerment variables. The variables include participation in community health, participation in community education, if the family have joined Jangi groups, if they have joined support groups to support or to improve the lives of their children with disability. Next slide, please. This one shows the variable change for the health and education variables. For the health variable, we had about a 0.41 weighted average change in the health variables. The variables include if the child with disability have if the family discuss health issues with the child with disability, if they own a disability card, if they have health insurance, if the family is spending some time to bond with the child with disability, if they have completed their vaccination status, if they actively protect their child with disability against SGBV, if they respect hospital appointments of the child with disability, if the child need of assistive devices are being met. And to the education variables, we had about 22.2% weighted average change in the education variables, which comprise of if the child is attending school effectively, if the family assists the child with their homework, if the child with disability has all their school requirements, if the parents discuss the child's experiences in school, if they have a knowledge of what the child wants to read in future, and if the child with disability have access to technology for learning. Slide, please. And here we move to the variable for livelihood and social well-being. For livelihood, we had about 21.1% weighted average change for the livelihood variables, which include if the family has secured the source of income to support the needs of the child with disability, if they have if the family provides property or material inheritance for the child with disability, if they have secured a bank account for the child with disability, if they have legal documents protecting this child with disability, if they know the child's aspirations, and if they are actively protecting the child in conflict, particularly as Bamenda is a conflict-stricken environment. And to the social situation, we had about 10% weighted average change for the social variables that include if they assist the child in interacting with their community, if they talk to the child with disability about relationships, about marriage and things like that, if they spend some time telling stories with the child with disability, or telling stories around the house, telling stories in the house with the child with disability at the center of it, if they also allow the child with disability to make some household decisions like what should they cook today, what kind of movie should they watch today, those kind of things. And also if they know the child's favorite things like favorite musician, favorite movie, their best friend, if they also know their favorite actor, and if the child with disability have access to entertainment, access to technology for entertainment. Here we still have the variable change for empowerment. The empowerment category is particularly important for voice of people with disability in evidence-informed decision making. As suggested by research evidence, family participation in community health enhances collaborations between families and healthcare providers for better services as they raise their voice and express the issues through these structures. And it also provides relevant data for policy development and provision of specific services that are particular to children with disability. And also participation of people or families of children with disability in education allows for collaboration between parents and teachers of these children with disability. This will help the teachers to better understand how to deal with people with disability in academics, hence improving the success of the children with disability. Slide, please. Okay, here we have a picture of the disability card, which is one of the results that we are so much happy about. We in our project, we're working with 30 families. Many of them were able to get their disability card. This graphic here shows that with a disability card, you're able to access basic services. According to the national policy in Cameroon, it says that if a child with disability, or rather, the national policy provides free basic services for people with disability if they have a disability card, despite the fact that there are still bureaucratic hurdles that prevent people with disability from having a disability card. But through this project, working in liaison with the regional chief of people with disability, with policymakers, we were able to bypass some of the bureaucratic hurdles and making people with disability to be able to get their disability card, now having access to basic services. And engagement in evidence-based practices will improve rights and needs of people with disability. All these will join to improve livelihoods of children with disability. Slide, please. Okay, so far we have some results here. We have been able to impact on livelihoods of over 100,000 children with disability through policy influence. We have empowered 30 households or 30 families of children with disability with income generating activity. And the 30 families are actively engaging with their children with disability with evidence-based recommendations. This means that we are not leaving them behind again, the evidence-based practice train. Slide, please. Okay, now we go to the challenges and lessons learned during the implementation of this project. The first thing is the workload and timing. We had underestimated the workload and timing for this project. We actually anticipated that it was going to take us 18 months, but this has taken us up to 2 years because the research part took us a lot of time, more than we estimated. Also, conflict in Bamenda remains a problem to implementing projects. This evening the whole day I have been a little bit unstable because I have had my phone being bombarded with calls from fighting forces threatening me. This is one of the things that you get involved in working in a conflict-stricken environment. So this has also negatively impacted on our work here. And COVID-19 coming to, it's a double blow to us in Bamenda here. COVID-19 coming with conflict, it's a dilapidating blow on the faces of people. And we also have internet problems here, poor internet connectivity. The next challenge is that piloting an intervention or proof of concept can be very time consuming and expensive. And this means that funding and timing must be scrupulously planned. And also, this project involved a lot of innovative softwares or technology like MagPie, MaxQDA, Google Maps, Geomapping, and other softwares. Technologies that are required for accurate geotagging are expensive. Lower level phones may be problematic to use when dealing with research. And for our lessons learned or our joys, it's very exciting working with people with disability, and the impacts are more pronounced and fulfilling despite the challenges. And another lesson learned is that we are only as strong as our weakest link. This means that if one person in the team fails, the whole team fails. This project has been able to move to this level because of teamwork. The team at eBASE is a great team. The team of community health workers and everyone that has been actively engaged in the project made it possible. Slide, please. So for the future plans, we intend to further develop this toolkit, get more funding, and extend the work to the rest of the regions in Cameroon, and even extend it to Niger, Chad, and Nigeria. That's the Lake Chad Basin, and further developed this toolkit. Slide, please. So we go to discussion. Evidence-based policies have been developed for rights and needs of people with disability. However, the extent of implementation is still lacking. Family and community involvement in policy processes at decentralized levels are effective in facilitating implementation of policies. Slide, please. Thank you very much, and I share color notes with you.
Thank you so much. I share with you. If I could, I would give you a big bag of cola nuts because
thank you.
It sounds like on top of all of the challenges, you've had an especially difficult day today, and the fact that you were able to join us in spite of everything and to share this very exciting work. I'm just thrilled. I have so many comments and questions, but we'll first of all open it to the participants. So for those of you who joined a bit late, my name is Lynn, and we've been listening with Nain Mirabel. If it's possible, you'd like to make a comment, you can put up your blue hand if you know how to do that. And if you're not sure how to do that, you could just unmute your mic and go ahead and make your comment. I'm just looking to see if there are any questions or comments. Anyone have any comment, question? Okay, well, while we're waiting for you, I'm going to start with a couple of things that I noticed. Empowerment is a topic that we often grapple with. We're not sure really what it means. We talk about it. But it was really interesting to see how you have operationalized empowerment in this project. Is there anything that you'd like to say about doing that? Did your team have a lot of discussion, or was it easy to come up with empowerment indicators?
With help and guide from the WHO guidelines, this was not too difficult, but we still had to have these discussions with the families to ensure that these are the things that they will be happy to see as results, to say that their livelihoods or the livelihoods of their children with disability are being improved. So all these variables or all these outcomes were in discussion with them. So that's what we did.
Okay, thank you.
Yes, except Patrick has something he wants to add. I don't know.
No, I think you've put it very, very clearly. I think what really helped us with guiding on actually zooming on what empowerment will entail was our discussions with the families, like what would happen to you for you to feel that your child has been empowered or your family has been empowered. So this definition kind of really came from them, then before the WHO document that guided.
Thank you. I'm not seeing any blue hands. Does anyone have a question? You can unmute yourself if you'd like to ask a question.
Yeah, I have a question.
Go ahead, Kofi.
Yeah, I'm Kofi. I have a question regarding to the identification card. I want to know how reliable or how it is preventable for fraud. Either people other than disabled can get that card and get the benefits. I don't know if you have an idea about that. How reliable or how it is from fraud.
Okay, if I get the question well, Mr. Kofi is asking how reliable the disability card is. Is that?
Yes.
Okay. So it's a national document produced by policy makers. It's just like the ID card in Cameroon, such that the national policy stipulates that a child with disability is supposed to own a disability card. This disability card, to have it, it goes through a lot of process. You're supposed to go to the public hospital for the doctor to certify that you have this particular kind of disability. So after that, you go to the social affairs where they will process it, and then you have this card. So after getting this card, when you go to the hospital, you will have reduced, it has some advantages such as reduced health costs. So if you go to a child with disability goes to the hospital with a disability card, their health costs will be reduced because they have a disability card. If they want to go to school, they'll go to school almost for free. They have to just present this disability card and they'll go to school to whatever level of education that they want to go to. Also, according to the national policy, it says that if you have this disability card, you have reduced interest rates on loans. If you want to do business and you want to take a loan from the bank, you're supposed to enjoy reduced rates of transport. You're supposed to enjoy reduced rents, unlike the other person who doesn't have a disability. So people with disability in Cameroon are supposed to have this card to be able to access these free basic services. Does that make some sense to you?
Yes, please. Thank you.
You're welcome.
I've just added a comment in the chat that we also know that it's quite variable. I think you've described what the situation is supposed to be. In practice and in reality, people have a wide range of experience, although it seems to be improving. I think our advocacy, the collective advocacy efforts seem to be having some effect.
Yes, it seemed to be improving with time.
Great. Any other question or comment? Ellen?
Yes, please.
Just would like to know how you made contact with the families and the children living with disabilities.
Okay, so here in the community of Bamenda, when we started to locate, the first thing was to identify the people living with disability. So we liaised with some support groups that led us to some support groups of families of children with disability that led us to other families. So the idea is that when you know one person with disability, they will know another person who has a disability, and they will know another person who has a disability. And through the community health workers, we're able to go to their households, visit them, and interact with them, and invite them now for a discussion or stakeholder session where we discuss with them about the project and its intentions. That's how we get to link up with the families of people with disability.
And just a follow-up question to that, Nain, can you give us a bit of an idea of those 30 families? What kinds of impairments and disabilities are the children living with?
We have varying disability we have a mental disability, we have some who have a physical disability, we also have some who have hearing disability. Those are the main kind. We have autistic children as well. Those are the kinds of disabilities that we have among these 30 kids.
Thank you. Etienne, I think, wanted to make a comment or ask a question. Go ahead, Etienne.
Thank you very much, Lynn. Thank you very much, Nain, for your presentation. Thank you, Patrick, and the rest of the team. Please, I just wish to know from your introductory slide, you actually said the global prevalence of person living with disability is about 15, and in Cameroon 10.6, and in Northwest. Are these figures generally for children, and for the figures in the Northwest province, the data that is used for those figures, are they some that are really recent, maybe part of your work at some point and things like that? Please, thank you.
Okay, thank you for the question. The data we have is gotten from WHO and UNICEF. This has not been updated by these global structures. So for the global statistics of people living with disability, we have it at 15%. This 15% is all, including children, adults, young adults, or old people. Then in Cameroon, we have about 10.6% of people living with disability. This is global, children and adults inclusive. Then narrowing it down now to the Northwest, we have 23% of this 10% being children with disability, according to UNICEF.
So the 23% for the Northwest is for children living with disability. It's not even the total, including adults living with disability?
Yes. I think, Nain, you're saying of the people in the Northwest with disabilities, 23% are children?
Yes, 23 are children with disability.
I guess it's really important to understand these numbers, and we all know that we need more research in this area to really understand what kinds of situations people are living with. There's so many different ways of measuring or classifying people. So we have a lot of work to do. Luis, I think I saw your hand up.
Thank you, Nain. Thank you for the presentation. It's great that despite the challenges we're facing, you're able to to this presentation. Really interesting. I love the way you operationalize the different variables as found in the CBR matrix and giving evidence, empirical evidence about the interventions that you are doing. Is really informative, and it's more clearer for people to see. I worked in a community of practice for the past 4 years, focusing on disability and rehab in the Northwest region. One of the key things that we were discussing was how to harness efforts of different organizations. How are you in this project making sure that you are not duplicating efforts maybe, or how do you, I see you work with 100 or so children or people with disabilities and providing services that are linked to their empowerment and etc. So is there any effort made to maybe see where they are coming from and where you can lead them to, or what else? How do you harness these efforts? At some point we had, you could have one person with disability who, it's like you find organizations fighting to fighting to work with, say, oh, this is my person, this is my person. Do you in any way work based on, look at previous work that has been done and then move from there?
Hello, can you hear me? I think I lost you guys and then I came back. I just heard Dr. Lewis talking about if we consider previous work before moving. Was that all the question?
Yeah, I was trying to look at how do you avoid duplicating services in your project?
So since this intervention was an innovative intervention, to the best of our knowledge, getting research into households of communities or getting research into households and communities of people with disability has not been implemented in this community before. So we did not have that kind of conflict of interest.
And Luis, if I may also add, because we did a rigorous search, we were able to actually look at what everyone had done in the past. And we also looked at what the community of practice, I think one of the emails that some of the emails that we sent out was to people within the community of practice to find out any documents that they have, any reports, any experiences. And we actually used some from there to develop what we rolled out. In essence, what makes this different from most of the previous ones is the fact that you actually get into the household and you assess the practices that they are doing, what they are doing in a systematic fashion, and then you map this to best practice. What does best practice say, or what does research evidence say? What have previous people done successfully? And then you match it. So it's a kind of audit. So it's a kind of audit that allows families to kind of match their practice to best practice, if I may use the word best practice, to match whatever they are doing towards their children to what research has said is the best thing they should do. And then they score themselves, and then they try to do what is effective. So this is how it builds up to this level.
Thank you. Any other comments? I'm going to build on that then. One of the things that we've seen in some places is parents who become advocates for their peers, advocates for other families. Do you see this work moving in that direction eventually, that some of the parents who are involved in this project might, you know, be involved in supporting other parents? Or are you doing that already?
Yes, we are actually already doing that. It was very interesting that we actually had to at some point there were staff that were working on the project that realized that the parents or the families, there was a family that could, or a parent that could do that job and even better, because they could actually relate with the people, with the other families with disabilities, more than the staff that we had on the ground, because there were many aspects of empathy that wasn't exactly coming up in this staff. So we had to relieve this staff, and then we brought on board the family, the mother, and we actually had to pay her to, because we found out that she was a very good engine. So it's an experience that we came across.
Yes, also to add, we also had this family that was very active in helping the other families who don't have disability cards for their children with disability, because they have already acquired one, they know the process, they know how to put the documents together. They actually opted to lead them. So they rallied themselves and they went to social affairs, they put together their documents together, and then they follow up the process, and they were able to get their own disability cards. So some of the families are taking up that advocacy for other families, so that for the interest of all of them.
Thank you. Okay, I have another question unless somebody else wants to jump in. Okay, one of the things I noticed was that you reported that it was only about 10% of the families that had health insurance. And we know that health insurance in the Bamenda area is very difficult, both to obtain and then, you know, what it actually covers. We also know that it can be very helpful. And there is research in other places that shows that when you have an impairment or a disability, your medical costs are often much higher than average. So I'm just wondering what your thoughts are around health insurance and how the families responded to some of the conversations around health insurance.
Okay, so while some had already embraced the idea of health insurance, some were hearing it for the first time, while others thought that health insurance is just a scam. So with the discussions we had with them, they now understood that health insurance will rescue when you most need it. And it's actually one of the first things that you should be going for to secure the health outcome of your child with disability. So though after understanding, they expressed that it's difficult or it's expensive getting health insurance here in Cameroon. So one of the idea of the income generating activity, because we actually have an expenditure strategy for them. Some of the percentage will go to buy health insurance for the child. Some percentage will go to support the education of the child. And some percentage will go to create a bank account and put some savings there for the child with disability, while some go to support the family's need and a gift for the child with disability. So that is what our income generating activity is basically about, and how it tackles the insurance variable.
Thank you. There's also a question in the chat, and I think you've answered the question about how you chose the families who were participating. Maybe you can just clarify, are you continuing this project? Are you expanding to other divisions or other regions?
Okay, we hope to to expand this project to other regions and possibly to other nations, like I mentioned. But for this particular phase, this was a proof of concept, and we got funding that could only sustain up to 30 families. So we're hoping that at the end of it, we can get more funding and extend the work to other regions and to other countries. We actually wish that we can further it and reach more children with disability, because despite working with 30, there are still many in this Bamenda that are not able to be part of this project because the funding did not permit that.
Yes, so we know that there's still hundreds, probably thousands of families that could benefit. I see Elliot's hand up. Please go ahead, Elliot.
Yes, hi everyone. I had a question. I want to know how the parents are supported. How much support do they get, and what type of support they get to help their children?
Hello. Okay, since Nain, I could go on. It looks like Nain is not there. So the support that goes into the family are in two forms: in cash and also in support from the community health worker who visits them on a monthly basis and does an evaluation of the practices that are going on around the child, and then uploads this to our servers. We analyze this, and then they give feedback. We make recommendations on how they can improve on the 5 points that Nain mentioned earlier on their health, their education, their social well-being, their livelihood, and then their empowerment in general. So it's as she also said, this was a proof of concept, and there is more detailed economic evaluations that's done on the project, which was not presented here, but they had an equivalent of about $200 per family to start off an income generating activity. And when we estimated how much it would really impact on the child's life if we had to make an investment for an income generating activity, it was going to be at least $1,500. So we were way below what was expected to be ideal. And how did we estimate what would be ideal for the child's investments? We estimated that the child would be able to cover the cost of their education from the income generating activity. They'll be able to cover their medical bills. They'll be able to cover their, to pay for health insurance. And then they would also, so that the project itself doesn't cause a problem of Joseph and the coat of many colors, which was something that we were seeing, that once you pay a lot of attention to the child with disability in the household and you leave out the rest of the family, you could actually make that child to be a center of jealousy from the siblings. So somehow the project has to be, the income generating activity has to be able to also make the rest of the family feel something coming their way. So these were the estimates that we made at this stage. And of course, as we said, it's a proof of concept. We would probably need funding to do a bigger pilot program to test and push some boundaries. Thank you.
Thank you very much for your answer.
Thank you. I think we're just about out of time. We did start a little bit late, so I'm allowing us to go a little bit late. Any other comment? I see one that was given to me privately, which I think most of that has already been answered. Okay. Nain, are you back? I think you're back. So
Yes, I am back.
I just, on behalf of everyone, I will ask people to unmute themselves in a few minutes, but just want to thank you so much once again for taking the time to prepare for this session, to be here at the right time, despite the many, many challenges that you've had. It is such a pleasure to hear about your work, and we're just so happy that you're managing to continue on despite all of the challenges, and we wish you all the best in continuing on. You know, the problem with doing this kind of good
Thank
work,
you very much, Lynn.
the problem with doing this kind of good work is everyone wants to work with you. So you will be hearing from many people, I think, that they want to, you know, we will all want to be working with you as you go forward in doing your pilot and in doing the next steps of this project. I'm also going to suggest that we ask someone from eBASE to do some sessions for us specifically on some of the software that you've used. I think you know, in the Institute, we talked about geolocation, geomapping. Sarah is going to be helping us with webinars in the new year. And I think it would be really exciting to have a session on you know, geomapping and different things that can be done in research. And then you're also using some other really interesting perspectives. So both from setting up a research study and then collecting the data and then doing the data analysis. There's just so much to learn from your team. So thank you very much to all of you. Anyone else have a comment they'd like to say? I see some chat comments, but if anyone would like to put on their microphone and make a final thank you or two, please go ahead.
Bravo.
Go ahead. Okay. It really is amazing work. So thank you all. Our next session will be December 16th. And we're going to be talking about using checklists for accessibility. So there are a number of checklists that you can use for things like your documents or for things like planning a project. We will have 2 or 3 speakers talk about different tools that can be used, and then we'll have some time for discussion. And Nain, I forgot to mention, but I was really impressed how you presented a lot of information, but you also left time for discussion. So thank you very much for that. So hope to see you all in December for our next session. Have a great evening, great afternoon. All the best. Bye for now.
Thank you, Lynn, and bye for now.